Now, we've talked about it a little bit during the last few days and throughout the past 2 years, or actually from the beginning of my endoscopic career on, I've asked colleagues, experts at the time, how do I set my pump, or how do you set the gravity to be effective, but on the other hand, on the safe side as well. And I felt like I never really got a good answer. I mean, you have all these experts giving you recommendations, set it to 30, set it to 40, raise it if you need to during bleeding, but not for too long. But nobody could ever really give me a sufficient, satisfying answer based on any kind of science. So over the years, I just started trying to figure out some scientific data about it. First of all, why do we need irrigation? Well, obviously, it's to keep our visual field clear, to wash out fragments. And we've already heard a nice presentation about the surgical site infection reduced during endoscopic procedures due to the use of irrigation. Joseph, you're not paying attention. All right. Now, the problem on the other side, if we use irrigation, is... I'll ask you some questions about it later. So, on the other hand, we have complications very specific to endoscopic spine surgery, which are possibly associated with irrigation, such as headache, seizure, visual disturbance, hypotension, and so on. And also, a study which I published together with some colleagues showed some very severe complications possibly associated with irrigation endodural tear. On the left-hand side, for instance, paraparesis due to subarachnoid hemorrhage following a cervical foraminotomy where a dural tear was caused, or on the right-hand side, intraoperative seizure due to intracranial air, also probably caused due to a dural tear during an interlaminar discectomy. Now, my part of that study, thank God, was not the complication demonstration, but this part, the survey. So I asked colleagues all over the world about what complications they had encountered, which they associate with, also associate with irrigation. And obviously, if you summarize it here, then more than 20% of the complications that colleague reported back seem to be related to irrigation. So again, the big question is, what is the standard setting? What is the safe setting on the pump? Obviously, we always start very low, 30, 40, but sometimes this is what it looks like under 30 and 40. And then, of course, you start raising the settings. But the question is, how far can you raise it and for how long? 60, 80, 100, is that all safe to do? Or even more than that if you have arthroscopic pumps? So anyway, apart from that study, which I just showed, next step was to come up with a cadaver experiment study. So we opened up the spine in the sacrum, opened up the thecal sac, introduced pressure probes intradurally up to the cervical spine, thoracic spine, and lumbar spine. Additionally, placed an epidural probe, closed it as watertight as possible. Additionally, placed intracranial probes, and then we simulated different settings. On the one hand, gravity with different height levels, starting at 0.5 meter, then 1 meter, 1.3 meter. And we used two different pumps, an arthroscopic pump, as you see here, with different settings, and also used a spine-certified pump with different levels. And eventually, then we simulated different procedures, interlaminar and transforaminal approaches in the lumbar spine, but also in the thoracic and cervical spine. And I'll just quickly, to not confuse you too much, go through a few of those results that we acquired during these procedures. Now, this was recently published as the experimental setup. Again, as mentioned, here are just a few results. Now, on the very top, you see gravity. In the middle, you see system 1, which is the arthroscopic pump. And on the very bottom, you see the spine-certified pump. And as you see on the left-hand side, we started with very low settings, 0.5 meter, 30 millimeter mercury on the pump setting. And then we increased it step by step. And we looked, while we performed an interlaminar procedure at the level L3-4, at the intradural and epidural pressures. On the one hand, while keeping the system open, so a continuous flow, but as you all know, to control bleeding, you can also occlude a working channel, occlude a second channel to locally increase the pressure. Now, the summary of it is obviously that no matter how high the pressure is during gravity or pump settings, And even when you occlude the working channel, you do not significantly increase the intradural pressure. Obviously, you increase the local epidural pressure, which you see on the right hand, the most significant increase. But again, the intradural pressure is not increased. So theoretically, in this scenario, we're safe. Now, this is a little bit more confusing as it doesn't only contain the lumbar results, but also the thoracic and the cervical results, but it's basically the very same thing. Even in the thoracic and the cervical spine, as long as the dura is intact, even with high pressure and gravity settings, the intradural pressure is not significantly increased. Now, the big question is, what happens if a dural tear appears? Things do change, of course, then. So again, real quick, same setting, interlaminar approach, L3-4, but this time with a dural tear, and now we're only looking at the intracranial pressure, again with gravity, arthroscopic pump, spine-certified pump, starting at low settings, going all the way to very high settings. Very surprisingly, in gravity, it doesn't make a difference, but if we look at the, no, it's not. I guess it's a little bit difficult to see, but if you look at the arthroscopic pump and the spine-certified pump, then already at pressure settings of 80 or in the spine-certified pump even at 40 millimeter mercuries, as soon as you occlude the working channel, the intracranial pressure rises above physiological levels. So this is, I guess, the most important finding and explanation of why these severe complications can happen. Now this, of course, brings us to the discussion of, do we oftentimes have a dural tear which we just don't notice because obviously we have irrigation running, we don't see CSF right away. Certainly is something that might add to that. Now, based on these findings, the question, of course, is, do we have to manage dural tears differently from now on than we used to? Like, especially, do we have to avoid occluding the working channel, or do we have to repair the dural tear immediately, or stop and convert? So these are all possibilities based on these findings. Now, real quick, dural tear, of course, is not dural tear. You can have very small, medium size, all the way to large dural tears. Now, there are studies out there, publications out there nowadays showing algorithms on how to treat dural tear. However, to this one, which was just recently published, I do disagree because especially for small dural tears under 5 millimeter, they obviously recommend no intraoperative management. And beyond that, they recommend bed rest. Bed rest is something we can discuss. Actually, there is a high quality study out there showing that there's no point in bed rest after a dural tear, but this is not what I want to focus on. Again, they recommend no management. So here you see a very, very small dural tear, but in contrast to the recommendation, I didn't not manage it, but immediately after I caused it, I put a small patch on there. Now, this is not because I'm worried about CSF leaking, causing infection, pseudomeningocele and all that. If I still have a little bit to go within that procedure, I'm worried about irrigation fluid entering intradurally, increasing intracranial pressure, and possibly causing any of these severe complications. So again, in contrast to that algorithm, I do recommend that you even patch small dural tears, and ideally immediately after they happen. Now, of course, there are limitations to this experiment so far, but at least that's a beginning of scientific data, obviously, that we have to eventually hopefully get to where we can give good recommendations about pressure or pressure settings on the pump or gravity settings. Thank you.
Vincent, you have to ask a question to Joseph.
Oh, yeah.
How many was the pressure?
On the third image of the pump settings, what was the pressure on the left side?
I think I saw this topic 3 times.
And you still haven't learned it by heart. You should have given the presentation then.
Yes, maybe. But it's yours. Maybe 2 questions about the irrigation, about the outlet of the water to the endoscope, because many of the time we have the outlet right ahead to the endoscope and not to the side of the endoscope, and we can have some direct injuries and maybe more on the spinal cord? And what about the temperature of the water?
Yeah. Now, the direct flow onto, like straight ahead onto the spinal cord, I think that might be an issue if you have it at very high settings, where you sometimes even see how it indents the dura at least. So especially in the cervical spine, thoracic spine, I think that could be an issue of direct pressure on there. The lumbar spine, I wouldn't think, especially if you don't raise it up very high for a long period of time. I think it's okay. Yeah, temperature is always a good question. Once the procedures take, I don't know, 2 hours or more, patients are always freezing and shivering after that. I never tried anything different than room temperature, but so I can't really give you a good recommendation on that. Maybe you can help me out.
Vincent and Joseph, a question to both of you and maybe to everybody else. We started to follow your recommendation about adrenaline in the first 2 saline bags. Have you had any experience with adverse events with possible durotomy?
Adrenaline or not, and nothing after the surgery, but we have with all our team, and Philippe is here, we have the same protocol and more than 1,500 cases, and not complications after adrenaline. Philippe? Okay.
What's happened in your case? What do you think it could be? What do you think if it's come to the adrenaline? What do you think that?
What complications?
What is the complication? Why do you think it came from the adrenaline?
Ah, we don't know. Like when you realize your infiltration in the skin before your surgery to reduce your bleeding during the creation of your working space.
What's happened to those patients?
Ah, nothing.
What was the complication?
For the patient.
You just said that you have a complication.
No, during the surgery, we had the arrhythmia of a patient, and I told to the anesthesiologist, maybe it's the adrenaline. Oh, yes, we use adrenaline in the bags. Okay, but it was just a reflection for one patient. Or yeah, but
I'm asking because I also do some pain medicine, some spinal cord stimulation, and I do it in awake patients. And I had a complication also similar to yours, but with lidocaine, it possibly got into the vessels, and the patient had a seizure in the operative. She was awake. It was kind of
during UBE.
no, spinal cord procedure.
Okay.
Therefore, I was asking myself if there are any complications with the adrenaline that we put in the saline bags, because it's obviously it's a great help for the beginning, for the establishing the working portals, and don't have any bleeding inside.
Okay. And I spoke about the outlet of the water because with some arthro pump, you can reduce your pressure less than 15. And we always ask for a postoperative MRI at D1, and even if you have patients who are good without symptoms, sometimes you can see T2 hypersignal on MRI on the left side. And we are afraid by this, and we are discussing with the industry to maybe develop some other endoscope to have an irrigation to the side of the endoscope and not straight ahead.
Mm. Yeah,
I think for the decompression in cervical, it will be really important.
Yeah, yeah.
Yes.
No results. No difference. Haven't seen any difference. I've been using that kind of shift, not the direct flow. From the beginning.
Very nice presentation.
Just a quick last comment, because we talked about adrenaline in the back, and somebody has mentioned it yesterday. I don't know, Joseph. Do not put tranexamic acid in the bag. I mean, use it very liberally as IV in advance, but do not put it in the bag, because it's neurotoxic and you might not know when you cause a dural tear, or you just don't notice it. So never put tranexamic acid in the bag. IV is absolutely fine.
Thank you, Vincent.
In terms of UBE and pressures also, I think it would be interesting to know the influence of the outflow and other variables. I'm doing a study in cadaver also to know the depth of the patient, the size of the incision, and some type of variables that we do normally, like putting our hand in the incision, and it dramatically alters the epidural pressure. I didn't measure the intradural pressure per limitations of the study, but it's very interesting that small things like the depth of the patient and the size of the incision can make a big difference.